All right. So the guidelines were first created in 1994, then they were revised in 2011, and most recently in 2022. Can you tell this is my first webinar? Now my slides won't. There you go. So at birth, I mean, you've all been through this, but just to go through what the guidelines say. So at birth, the baby will get a thorough evaluation, physical exam, to look for any medical issues that you guys have already stated you're very familiar with: heart problems, gastrointestinal problems, feeding issues, eye problems. And I'll just go through the heart problems. I like these pictures because it's from the American Heart Association. So the typical structure of the heart is in figure A, with the atriums on top and the ventricles on the bottom, and the muscles in between, and the blood vessels and the valves. So the first heart problem that's one of the most common in people with Down syndrome, and about 50% of people with Down syndrome do have heart issues, is the atrioventricular canal, or AV canal, where there's a hole between the ventricles, there's a hole between the atrium, and so the blood mixes. So the oxygen level is not as good as without the holes. So this needs surgery and be followed by a cardiologist. Again, the normal anatomy at the top. Sometimes there's just one hole between the atrium, which is called an atrial septal defect, or a hole just between the ventricles, which is a ventricular septal defect. These need to be followed by a cardiologist. Some of them don't need surgery, some of them do need surgery. So cardiology is very important for people with Down syndrome. And then tetralogy of Fallot is not as common in people with Down syndrome, but still does occur. And that's when there's 4 different problems. There's the VSD, there's a thickened muscle in the ventricle, there's a problem with the pulmonary valve, and then the aorta isn't quite in the right place. So that needs surgery. And then patent ductus arteriosus, when the baby's inside the mom, there's a blood vessel that's open to keep the blood going to the placenta instead of the lungs. And then this is supposed to close after birth, but it doesn't always close. And sometimes it needs to be treated medically, and sometimes it needs to be treated surgically. Gastrointestinal problems, these aren't as common as the heart problems, but they're duodenal atresia. It still happens not infrequently, and that's where the duodenum, which is the first part of the small intestines, is not actually connected with the stomach fully, and so that will present with vomiting, feeding problems, not pooping. Hirschsprung's disease is much less common, and that's when there's not the neurons in the intestines, and so the intestines don't work right, and they develop a blockage, and that also can present with vomiting and not pooping, and also needs surgery to correct. So the testing at birth that is usually done after the thorough physical exam, there's some blood work, a karyotype to make sure the chromosomes are what we think they are, even if there has been prenatal diagnosis, and to clarify the diagnosis. A blood count to look at the different types of blood cells. And then we want to check the thyroid function. In Ohio, usually that's done by the state newborn screening, metabolic screening. In some states, it's not done through the state metabolic screening, and then it has to be done separately. Thyroid disease, we'll talk about that later, but very common in people with Down syndrome. So some other tests that should be done at birth. All babies should get an echocardiogram, even if they have no murmur, no signs of heart disease, just because heart disease is so common. And some of the heart problems don't show up until after the baby might go home. Every baby with or without Down syndrome gets the hearing screen. Very important for babies with Down syndrome because there's a higher rate of hearing loss. A car seat challenge. You guys are probably familiar with this, but to have the baby in the car seat and check the oxygen and the level and the pulse, just because their airways are floppy and their necks are not strong and their heads can flop over. So that's to make sure the baby's oxygen stays normal while they're in the car seat. I just want to say a word about transient myeloproliferative disorder. That's one of the reasons we get a blood count in the newborn nursery. It's not all that common, but it can happen in babies with Down syndrome, and it definitely needs to be known about. It's when there's an increased number of immature white blood cells in the blood count. Most of the time, this goes away by itself, but it does put the baby at risk for leukemia in the first 4 years of life. And it needs evaluation by a pediatric hematologist to make sure it goes away and to keep following to make sure it doesn't turn into leukemia. So at birth to 1 month, there, as you guys know, it can be a flurry of activity and medical tests and surgeries. Some babies go home from the hospital within a few days, and some babies get transferred to the NICU and stay for a longer time, can be a long time, to deal with heart issues and feeding and oxygen and everything like that. So very important is we monitor feeding and weight gain, especially in the babies with the heart defects. You have to, make sure they're getting enough calories, but they don't get too tired, and make sure they're not going into heart failure. You guys all know about that. Breastfeeding can be very difficult with babies with Down syndrome, though it's great for them. And if a lactation consultation can be very helpful. And there are some good websites and references on there too. A lot of people do need to supplement if they breastfeed, and then some babies have trouble even bottle feeding. I mean, Chris was not a great bottle feeder even, so that was a challenge. And then some babies need the NG or G tube, and feeding is a big issue. Also, at birth to 1 month, we want to make sure everybody gets hooked up with early intervention and gets into therapies. And then safe sleep, just like every other baby. The baby needs to sleep on their back alone in the crib, no pillows or blankets or things like that they can suffocate with. So from 1 month to 1 year, we're also paying attention to feeding and weight gain there. And there are specific growth charts for babies with Down syndrome. And these can be especially helpful, I think, the first year, when babies with Down syndrome tend to be small. Sometimes after that first year, babies with Down syndrome or people with Down syndrome can tend to gain weight very quickly, so you gotta watch that also. A repeat hearing test at 6 months, even if the newborn one was normal. And repeat thyroid testing at 6 months and 1 year. There are babies who had normal testing at birth, and by 6 months, the tests are abnormal. And thyroid hormone is very important for normal growth and development. So most people with Down syndrome who have thyroid problems have low thyroid or hypothyroid. Some people have hyperthyroid. Hypothyroid, low thyroid, is treated easily with oral medicine. Hyperthyroid is a little more difficult, but that would be handled by an endocrine doctor. By 6 months of age, want the baby to see an eye doctor who knows about pediatrics and people with Down syndrome. And again, at 1 year, you do a blood count and a test for iron deficiency. And then the vaccines are per the usual schedule. Some babies, like babies with significant heart defects or heart surgery, or who were born prematurely, might qualify for RSV prevention. That RSV virus is that bad wheezing virus in babies that can cause bad pneumonia, wheezing, end up in the intensive care unit. Again, much worse than COVID for babies. So definitely something to talk to your pediatrician about if if your baby had surgery or was premature, or just you want to ask about. Okay, then before we get to the older kids, I just want to go over some concerns that really are there throughout childhood, make sure everybody knows what they are, and then we can talk about age-specific recommendations for that. Okay, so obstructive sleep apnea is very common in people with Down syndrome, and that's when you might hear snoring, you might hear pausing, there might be restless sleep, daytime sleepiness, the child might sleep in a funny position. Also, sometimes there are no symptoms, and it's just the airway is a little floppy and can. Hi, how are you?
There, go ahead and say hi.
Hi.
Hi, thank you for coming. Thank you for coming and joining us.
What do you say?
Thank you.
No, you say you're welcome.
I'm welcome.
Okay. All right. We definitely watch out for weight gain and obesity. I've seen some of the skinniest babies with Down syndrome start to gain a lot of weight, and that puts them at risk for sleep apnea and a lot of other things. So that's something to keep your eye on right away. Blood abnormalities, even if the blood work was normal initially, there is a risk for leukemia. Sometimes people with Down syndrome, their platelets don't work quite as well, so there can be bruising or petechiae. There can be low platelets, so that's something we always keep an eye on. And if your child is having, if a child is having easy bleeding, easy bruising, fevers, bone pain, those are the type of things that the doctor wants to know about. I want to spend a minute on atlantoaxial instability, because so it's not common. Only about 1 to 2% of people with Down syndrome have symptomatic atlantoaxial instability. If you have it, it's a big risk for hurting your spinal cord. So here's a picture I found. So these are the vertebrae in your neck, and the first one is your atlas, and the second one is your axis. So with people with Down syndrome, the low tone is even in their ligaments and things sometimes. So where the bones are in the proper position, if you're sitting nice and straight and your head's normal position, when you put your head forward or you put your head back, the bones can move, and then it presses on the spinal cord, and it can end up hurting the spinal cord. So that's why we want everybody to be aware of it. Even though it's not very common, we want everybody to be aware of it. Per the American Academy of Pediatrics, they don't recommend a routine x-ray. In one of the guidelines, they used to, I think it was the 94, they used to say do an x-ray after 3 years old, because before 3 years old, the bones aren't really, there's cartilage, so they don't show up. But then there were some studies that showed like you get very varied results if you repeat the x-ray, and it's not very good as a screening tool, unfortunately. So that's left with looking for symptoms or signs on physical exam. So from the American Academy of Pediatrics, you should contact the physician immediately for an x-ray of the neck in a neutral position. That's, just not bent forward, not bent back. If there's change in how the child walks, uses their arms or hands, a change in bowel or bladder control, like obviously before potty training, you wouldn't know, but if there's a change after that, if they have a tilted head, if they say their neck hurts, if they feel weakness, if they're not walking or doing normal activity level or functions. So then you would want to call the doctor, and so they do the x-ray in the neutral position. If it's not normal, or if the symptoms persist, then the child should see a pediatric neurosurgeon or a pediatric orthopedic surgeon. I trained at Rainbow. I know at Rainbow, it's a neurosurgeon. I'm not sure about the clinic in Metro, if it's a neurosurgeon or an orthopedic surgeon. And this is also a good link that you just, want to keep this in the back of your mind with all the other things we all keep in the back of our mind all the time. That's why we can't sleep at night. So, and then there are some recommended precautions for about atlantoaxial instability that for all children with Down syndrome, whether or not they have any symptoms or not. So you want to avoid like excessive flexion or extension of the neck during any anesthesia, surgery, x-ray, dental procedure, anything so we're not pushing on that spinal cord. The AAP recommends avoiding trampoline use unless it's part of a specific training program with appropriate supervision and safety measures in place. They just want to make sure everybody knows participation in contact sports such as football, soccer, and gymnastics does place children at risk for spinal cord injury because, you know, obviously your neck can go in all kinds of positions there. Okay, all right. Any questions about atlantoaxial instability? You know, it's probably, you know, it's not that common, but I just want to make sure nobody has a question about it. We're good? Okay, moving on to some other common concerns. There are some co-occurring developmental issues that can happen with people with Down syndrome. Autism is one of them. You know, interestingly, it's people with Down syndrome and autism generally are considered more social than people with autism without Down syndrome. It does make it a little bit more challenging to diagnose. A significant amount of kids with Down syndrome might have attention deficit disorder. There's also just attention and impulsivity and things that are just part of Down syndrome that wouldn't quite meet the criteria for attention deficit disorder. So that can be a challenging diagnosis too. Behavior concerns are very common, and you know, we always are taught, you know, you want to find out the function of the behavior. Like, is it avoidance? Is it frustration? Is it, you know, attention getting? Is there a medical cause for the behavior? That, like, are people in pain? So, you know, to try to find out what the cause of the behavior is always helpful to, you know, determine what to do about the behavior. Regression, again, this is not very common, but when it happens, it's very serious. So it's something that people should know about. And it usually happens in late childhood, teenage years, or adult years. And this is when somebody who had a level of functioning suddenly loses skills or loses ability. Like some of the kids, you know, usually were in mainstream classes in high school, and suddenly they're not taking their shower, or they're not talking, or they're not feeding themselves. So regression is a very specific concern, and most general doctors wouldn't know a lot about it. So then you would really want to seek out like a Down syndrome clinic and go from there. This is a very good, DSMIG is Down Syndrome Medical Interest Group, and they're doing a lot of research and collaboration with people who run Down syndrome clinics across the United States. And this is their statement on regression. They have a lot of good resources on their website, and these are like the experts on Down syndrome from all across the United States. It's and parents can go on the website too. There's a small members only section, but parents can go on it too. And you know, they're really trying to come up with the diagnosis and treatment of regression. We also are always worried about our children being at risk for abuse, because people with developmental disabilities have a higher rate of abuse. And as the children get older, it's that you want to, you know, be pretty honest with them about their body parts, what's appropriate, what's not appropriate, being careful with who they're with, because unfortunately, most kids are abused by people they know, not by strangers. So it's you know, an unsettling topic. It's important one to talk to child about. Okay, there are also several common autoimmune diseases that happen in people with Down syndrome. Celiac disease is a gastrointestinal disease that is a sensitivity to gluten, and it affects the intestinal like tissue and can present with abdominal pain, diarrhea, constipation, behavior changes. It can have no symptoms. So there's not routine screening for it, but if there's any screening, if there's any symptoms, then that's something to talk to your child's provider about, because then there are recommended blood tests to screen for celiac disease in children with symptoms. Thyroid disease is considered autoimmune. Type 1 diabetes. Alopecia is when the people with Down syndrome or anybody starts missing either big patches of hair, or some people lose all their hair. And there's been some interesting studies on some immune and drugs that have had some good results, but also can, got to think about the side effects. But if your person would have that, there are specialists who know about alopecia in people with Down syndrome. Another thing that you would probably want to contact a Down syndrome clinic about. People with Down syndrome can also get a very specific type of arthritis that would present with swelling, redness, or pain in joints. Older people with Down syndrome are at risk for gout, but not the children. There's a lot of skin conditions that go along with Down syndrome, very chapped skin, lips, face. They can get little pimples and folliculitis around hair follicles, and those are very common. Moya disease it's an interesting thing how they say it. It's not that it's that much more common in people with Down syndrome, but people who have Moya disease are more likely to have Down syndrome. It's not that people with Down syndrome have a really great propensity for this, but people with Moya, more of them have Down syndrome. And it's a very, it's a blood vessel disease going up the neck and into the brain that can present with strokes and TIA, transient ischemic attack, like symptoms like trouble speaking, face not looking right, weakness in your arms or legs, some neurologic change. And that you would want to call your doctor right away for that, and just have that in the back of your mind too, that it is more common with people with Down syndrome, and I think it does tend to present in childhood. Dental care, we always are thinking about dental care. People with Down syndrome tend to have more gum disease, and that's something you want to start pretty early on, brushing and flossing and getting dental care. And then people with Down syndrome, their immune system is not as strong as other people's, so they are at risk for infectious diseases, especially pneumonia, as we said, RSV, but also bacterial pneumonia, also influenza. Adults with Down syndrome, when they were over 40, back at the beginning of COVID, a 40-year-old with Down syndrome had the same severity of COVID as an 80-year-old who did not have Down syndrome. Luckily, the adults, the studies were mostly on adults because the child's vaccines weren't out, but luckily they did respond, and it's made a big difference in keeping people with Down syndrome out of the hospital, which is very important, because when it was back where care was getting rationed and things like that, and people couldn't be with their person with Down syndrome, it was really hard on families. Okay, so now I think we are in the 1 to 5 year. I still can't get that thing down off my top, but I think we are in the 1 to 5 year old age range. So, every year development is monitored, and as with all children, screening for autism is recommended at 18 to 24 months. So this would be something if your child has a speech therapist or a therapist who is pretty familiar with the typical time progression of people with Down syndrome in speech, this would be when the person with Down syndrome didn't seem to be fitting that typical social interaction and the typical language milestones, which can be complicated to figure out that it's something we want people to be aware of. And this is a very good article. George Capone, who is at Kennedy Krieger from Johns Hopkins, this is a very good article about autism and Down syndrome. As I said, we want to begin dental care because to keep that brushing and flossing. People with heart issues want to check with their doctor and see whether they need antibiotics before going to the dentist. And this is the National Down Syndrome Society has a nice resource on dental issues. Okay, and then we want to do a sleep study at 3 to 4 years, even if there is no sign of sleep disordered breathing. So even if there's no symptoms, at 3 to 4 years, there should be a sleep study. If there is signs of difficulty breathing, then one can be done before that, but definitely want to do one at age 3 to 4 years. And every checkup, you monitor growth, assess for feeding issues, choking, aspirating, things like that.
Hi, Suzanne, is it possible to ask a quick question?
Sure.
Okay, thank you. I had never been aware of the sleep study suggested at 3 to 4. Yeah, I guess, could you just speak a little bit more on that? Would that, again, I understand the basics, that if something is really apparent, then they would be able to catch that. But is that, primarily what that is going to serve to help with?
Yeah, so it checks for sleep apnea, so the obstructive sleep apnea, which a lot of times it would present with like snoring, pausing in the breathing, kind of like the snore, 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 pause, then noise.
Right.
People, but it can be, their studies have shown that like parental reports of whether their child has just trouble breathing in their sleep, that people are obstructing and it's silent and you can't hear it. So the sleep study, they unfortunately sleep overnight. They have the pulse ox, the oxygen thing, and they Chris had one when he was little, so he hasn't had one as an adult. And they monitor the oxygen level. I think there's an EEG. I think Chris had an EEG on too, so that they can see if there is trouble breathing in the sleep. Not all areas are great at having the resource of a sleep lab, but it's definitely something to ask about, because you don't want to have a low oxygen level all night.
Right. What would be the treatment, I suppose, after that? Because I know adults on both sides of my family that have sleep apnea and they have sleep machines, but I can't, is it imaginable or unimaginable to have a 3 or 4 year old that would need that? Hopefully not, but I don't know.
Well, no, some do. Usually what happens is you see an ear, nose, and throat doctor, and they can discuss. Sometimes they do take the tonsils out or the adenoids out. Sometimes it's, in adults, there's this new thing, a hypoglossal nerve stimulator, but it's still it's investigational. You would want to see an ENT if the sleep study was abnormal, then you would want to see an ENT familiar with people with Down syndrome.
Okay. And finally, with that sleep study, what you had mentioned, your son had it, and they have them there overnight, which I understand, but they do have a mask or something that they place over the face or on the mouth so that they can monitor. Is that correct?
Not during the sleep study. That
okay.
They use oxygen, and I think it's the chest strap and the EEG lead. At least that's from my memory with Chris. The
Okay.
breathing mask, what we call CPAP, continuous
Yes.
positive airway.
Yeah.
And that would be up to the ear, nose, and throat doctor.
Right.
A
Right.
lot
Okay.
of it with Down syndrome are on CPAP
Okay.
machines.
I just wanted to understand the sleep study a little bit more because I don't.
Yeah.
Yeah. Just to know if you would actually uh, be positive and
Well,
be able to get through that.
Yeah.
Mhm.
Yeah.
Okay.
I'll talk about that on the next slide. But
Okay.
so every checkup, we're still going to monitor growth, assess for feeding issues, do the blood work, and then yearly vision and hearing screening, and then just make sure, like, you know, you're keeping out for those signs of atlantoaxial instability, and the provider should be doing a neurologic exam to look for any signs of weakness or any signs of something happening with the spinal cord. So just maybe touch, just, you'll have your guidelines and you'll know, just double check that everything's being done. And then the vaccines as usual. And then as you were talking about getting the child to do the sleep study, procedures do get a lot more difficult at this age. The dentist, the blood draws, the sleep study. So Charlie's clinic is a Down syndrome clinic in California, and they have a lot of social stories that can help prepare for the different procedures. So to kind of, a social story kind of tells the child what it's going to be like, and you can role play and things like that. Hopefully you have time to do those. Because people with Down syndrome have very strong memories, like, getting their ears cleaned out once and then they're not going to check their ears a year again.
Yes. Well, thank you for that. Yeah, because we had a negative experience with the hearing test, and the individual clearly did not have experience with anyone, I don't think, really with special needs. And he said, "Oh, well, we can just try this again in a couple months." And I'm thinking, that's not going to happen. But
yeah, and
yeah,
the date people for everything. I mean, Christopher's had like 7 MRIs, and luckily he's one of the people who falls asleep. The MRI tech said like half the people panic and half the people fall asleep, and we were so lucky for every 7 MRIs. So
that's great. Okay, thank you.
You're welcome. Okay. All right, so now we're going to start potty training. So it's a good time to start talking to kids about their body parts and appropriate touch and privacy and what you do where and things like that. And then Global Down Syndrome Foundation, another great source for resources and webinars. Dr. Lena Patel is, I think she's a doctor of psychology. She has a very nice potty time handout, and she does a lot of good. She has some behavioral webinars too that are really good. Hey, Chris. Hey, do you need me?
No, I'm just coming in.
Okay. All right. You can stay with me.
Okay.
Okay. And then at 3 years old, it's important to know that responsibility for services and education transition from early intervention to the school district, and the child needs a multi-factored evaluation and to start on an IEP. And, this is a time where you really usually have to start being an advocate for inclusion and services and extended school year and things like that. And DeSanio has a lot of, that's not really my forte, but DeSanio has a lot of very knowledgeable people and programs about that too. So from 5 to 12 years old, as always, we're monitoring the weight. And starting at 10 years old, we look at the BMI on the chart, not specifically for people with Down syndrome, to start gauging the weight status. Because many teens and adults with Down syndrome gain a lot of weight, and it puts them at risk for medical problems, especially sleep apnea, type 2 diabetes, and joint problems. I was on the board of the National Down Syndrome Congress, and I've gone to a lot of conventions, and I've seen a lot of like 5'2" people who weigh like 300 pounds. So it's really important to start early on a healthy diet and regular exercise. Unfortunately, people with Down syndrome only need about 60% of the calories of a typical person. So don't we talk about this all the time, Chris?
Definitely, yes.
Okay. So, and I just want to show you the growth curve. This is why we start using the typical BMI curves, because if you see the solid red line is the 50th percentile BMI for Down syndrome, and then the little dashed line is the 85th percentile for people without Down syndrome. And 85th percentile is when we start to consider people overweight. So the average person with Down syndrome would be considered overweight. And you see how high that red line goes. So, you know, just because that's where the weight range is of people with Down syndrome, it doesn't really mean it's a healthy weight range. So that's, you know, so for the BMI, you would really want to use the typical curve. You know, continuing to monitor development of behavior, especially as you transition to middle school, where, you know, the class structure might be different, the teachers might be different. You know, you might have to be more independent. So doing chores at home, increasing the child's independence in the bathroom and daily living. Advocate General is one of the biggest adult Down syndrome clinics in the country, and they have a lot of great resources. And I found those resources on bathing and showering and toilet hygiene, which can be, their arms are short and they can't reach, and it can be, so those are some good suggestions. As with all kids going to middle school and even elementary school now, you want to talk about social media and internet use. People with Down syndrome, again, as I said, have these very good visual memories, these like holographic memories. So they can really, if they see content, they can replay it in their head and then they might act it out. But that also the judgment is not quite there on, you know, so monitoring internet and social media use is very important. Discussing puberty. The timing of puberty is not delayed in people with Down syndrome. It happens about the same time as everybody. So, you know, most girls with Down syndrome do very well with their period, but sometimes it does take a little work to figure out exactly how you do things. So again, Advocate Resource has some very good ideas on that, including like a story, a specific picture story about exactly how to do things. And they also linked to a New York Times article that reviews alternative to pads. They're called period panties, and these are washable, but I know some people also use like just the poise or the things women use once stress incontinence. So those are alternatives to having to change your pad, but those are some very good resources. Also, to help with puberty, dating, starting to talk about sexuality, things like that, Terry Cowenhoven is she runs a Down syndrome clinic in Wisconsin. She's a sexuality educator, and she has a daughter with Down syndrome. I think it's a daughter. And she's like the expert on puberty and Down syndrome. So her books are great, A Girl's Guide to Growing Up and The Boy's Guide to Growing Up. She also has done a couple podcasts, and she has other resources too, and she'll do webinars for family groups and things. Children's Hospital of Pittsburgh, Kishore Velati, has a lot of good podcasts, and these are Terry Cowenhoven's 2-part podcasts on puberty. So those are really helpful. And then, again, always assessing hearing and vision, the blood work, and the vaccines as the normal schedule. So, and then this is the link to the 1-page handout that really reviews everything in one little thing. So I'm going to stop sharing and I'll show you the handout. So if you go to the links at the very end of the 20 pages or whatever, it's supplemental material, and it's this very nice table that lists what is supposed to be done and when it's supposed to be done. So you can read. I would recommend reading the whole guideline, and discussing them with your child's doctor, but then you can take this with you as a reference. And then healthychildren.org eventually has very nice handouts by age that are just a couple pages that you can just get the one that's appropriate for your child's age. All right, so that's the end of my presentation, but any questions or comments or
I have a question about thyroid.
thyroid?
Like the thyroid panel every year. Like I know I've asked, I know there's like a set like recommended thyroid panel, but I have asked for a couple other ones and our pediatrician said it's not necessary to look any more into thyroid other than like the T4 and the TSH. Because I've asked for the T4 free and there's another one that I have to go back in my notes and look for, but she said it's just not recommended. And it's not necessary to look that far into it.
I think usually what they, let me just check and see for sure.
She only will ever order the TSH and the T4.
I thought they recommended free T4 and a TSH. Let me check for sure.
That might be it, but then I asked for just a T4 also. There's another one I always ask for and she says it's just not.
Not helpful.
Yeah.
Yes. Okay. Yes. So they do say TSH and free T4. That is the typical ones, and depending, there are some other ones like antithyroid antibodies that sometimes get measured depending on, sometimes the labs will go up and down and change. The free T4 is the active hormone. So that is the one we pay the most attention to. But, if you have more questions, I would, take the guidelines in and discuss them with her, with your doctor provider, because sometimes we do check antibodies and things like that. It's an individual child type of thing.
Okay.
What do you want to say, Chris?
I'm back. I'm an artisan in Article 21. So I've been doing crafts for people, and I actually got an order from my brother's friend who went skateboarding with him. So if any of you have any animals, you can contribute that to the Article 21 online shop.
Thank you. So Krista, I'm not sure if you guys all know what Artful 21 is. It's just audio again, and it's an online and in-person shop that people with Down syndrome make crafts. So Chris does stitching, and he can do a stitching based on a portrait of a pet, and he got an order for that yesterday, and he was very excited about it.
Yes, and I also do monograms also. Just as a side note.
This is a side note.
That's great.
Okay.
Thank you, Chris.
Laura, I had a question
Yeah.
regarding circumcision. So Riley, he couldn't be circumcised when he was born because he needed his heart surgery. And we kind of have been waiting to see what the doctors recommend, if there's a pro or a con versus one or the other ways we go. What are your thoughts on that? Or for hygiene reasons, is it better to do one way or the other?
I can't really give specific medical advice, but really, thank you. It's usually something to talk to your family and your doctor about and see what is the best thing for you and your family.
Okay, thank you.
It's, sorry, I can't give specific medical advice.
No, that's okay.
I'm not in practice anymore, but it's really something that your pediatrician probably discusses all the time.
Okay,
So,
thank you.
And also talk to I don't know if at this point it would need anesthesia or anything like that, but there's all that stuff to think about.
Right. Okay, thanks.
Okay.
Are there any questions for me?
Okay, Chris.
I'm just asking.
Okay. I love it that you're here. Let's see what's going on. Okay? Okay. All right. Okay, well, I thank you all for coming. And if nobody has any more questions, I'm going to close up, Chris. Okay?
Oh,
Okay. And I'll be sending out a Word document to everybody who RSVP'd. And feel free to email me if you need any references or educational material on anything.
Great. Thank you so, so much.
Thank you.
Okay.
So,
Bye, Chris.
Bye.
Bye, Chris. Bye, Laura.
Bye.
End your recording.
I just did. Okay.
Okay.